Hi, I'm Dr. Michael Urban, a staff scientist at the U.S. Army Institute of Surgical Research. It is likely that future enemy forces will increasingly rely on various types of explosives, short to long-range fire systems, and other weapons of mass destruction of the United States and its allies to unnerve, demoralize, and maximize casualties. This, combined with possible limitations to casualty evacuation, may put soldiers at high risk of blast trauma under isolated, hostile conditions. We know that blast trauma can cause rapid, widespread tissue damage, inducing a complex mix of nociceptive and neuropathic pain, headache, sensory hypersensitivities and impairments, sleep disturbances, and a variety of post-concussive symptoms that affect warfighter function. Further, combat and operational stress can cause allodynia and worsen normal and trauma-induced pain. Unfortunately, there are no focused pain management strategies for blast-induced pain. If pain signaling pathways are hyperactive or alternatively regulated, rewired, in response to stress, they may be more susceptible to the effects of blast. In this study, Sprague Deli rats were treated with 1 week of stress or unstressed treatments, followed by a single anterior blast, lateral blast, or sham trauma treatment, and then assessed using a series of acute orofacial and hind paw nociceptive measures over the course of 96 hours. Terminal blood samples were collected 2 hours after the final test, and animals were transcardially perfused and fixed. Tissues were collected for histologic analyses. Stress treatments consisted of 3 overlapping multisensory stimuli applied continuously for 7 days to produce an impending threat perception in the rats. Blast treatments were conducted using an advanced blast simulator in which isoflurane anesthetized animals suspended in the anterior or lateral prone positions were treated with a single blast exposure. Anesthetized shams were similarly treated with a comparable aversive auditory stimulus delivered at close range to the advanced blast simulator. We found that stress-free treatments did not alter pressure pain sensitivity in the temporalis muscle regions of sham trauma controls after 1 hour, nor did they elicit mechanical allodynia in the periorbital regions 2 days later. Further, neither blast orientation induced mechanical hyperalgesia in the temporalis muscle regions of unstressed or stress-treated animals at 1 hour post-blast, nor did they produce mechanical allodynia in the periorbital regions 2 hours later. While serum corticosteroid levels increased slightly for all treatments, the most pronounced was in the stressed and lateral blast treatment group. However, this was not statistically significant. No effects on weight gain were observed for any treatments. Though these results suggest acute orofacial mechanical nociception may not be affected by stress or blast treatments, analyses for the capsaicin wipe test, blue light photophobia test, and hind paw nociceptive test are still underway, which probes other types of nociception and regions of interest. It is also possible that the onset of blast-induced orofacial pain may be delayed. Hence, a second study examining later stages of pathologic development is currently underway. Thank you for your time.